Hello viewers from wherever you're watching us from around the world. You're watching QTV, the Gambia's first private TV station, and we are broadcasting live from our studios here on Kairaba Avenue. My name is Aliu Sise, and it's now time for your weekly State of Affairs program. Well, this week I'm joined on the program by Sen, who is the CEO of the National Health Insurance Authority. Mr. Sen brings over 2 decades, experience in the financial service sector to his new role as the CEO of the National Health Insurance Authority. And during this program, we'll be discussing about the mandate of the authority, the challenges being faced, and what next for the country health sector. Mr. Sen, thank you so much for coming on the State of Affairs program.
Thank you, Aliu, for having me.
For someone watching and hearing the National Health Insurance Authority for the first time, what exactly is it about and what's your core mandate?
Okay, thank you. The National Health Insurance Authority was established 3 years ago. The Secretariat was created around February, March of 2022. Yes, so the idea was to ensure universal access to quality and affordable healthcare for all Gambians. Yes, so that's our core mandate, providing universal access to quality and affordable healthcare. How do we envision to do this? We want to make sure we reduce high out-of-pocket expenses. Yes, because it's very difficult for families to be paying from their pockets for health insurance. It's unplanned, it can be expensive and very disruptive. So the idea of the health insurance is a social protection scheme. Yes, in brief. Yes.
And why do you think it is necessary to create this insurance scheme, in the Gambia at this time?
Yes, like I said, the mission is to provide quality, affordable and accessible primary health care for all residents of the Gambia. This is important because for a social protection scheme, you have to alleviate the suffering of the masses. Now, even for wealthy people, if you have some accident unplanned, most of your savings goes into taking care of your patient. And there is what we call catastrophic expenditure. So if you're not careful, after that you may never recover. So it's important for the government to come in and plan ahead, put people on a scheme that will make sure some of these negative outcomes don't happen. Yes. So,
and this is the first time that Gambia is having such. How have you been settling in this new role?
Yes, it's been a journey, very challenging. But when you are backed by strong political will, a lot of executive sponsorship, so it's always an opportunity to thank the authorities who are behind this. First of all, you have to understand that the health insurance scheme is the baby of the president, fully supported by the Honorable Minister of Health. So His Excellency conceives of the idea, gets his Minister of Health and Minister of Finance to support the scheme. Then we set up the Secretariat through the board. We have a good and well-experienced board chairman to spearhead some of what we intend to do. So the journey has not been very easy, but we are shouldering on. We started the scheme by doing what you call a pilot, to test the waters and see how we're going to do. So we chose Bundung Maternal and Child Hospital
That was in July 2023.
Exactly. Okay. Yes.
So why Bundung?
It's a good place with world-class service standards. I think a lot of the pregnant women, which is the area where we were focusing on, I think it's a very important sector for the country. Every household has it or plans to have it. So we chose Bundung because the services are world-class. Most of the women who have delivered in Bundung have a lot of praises for Bundung. So it was a deliberate decision to choose Bundung because we anticipated it will be a very positive experience. And it attracts people from the catchment area. If you look at most of the women who deliver in Bundung, they are not even natives of Bundung or Serekunda. They come from afar to get closer. So it was because we were hopeful of the positive outcomes of Bundung and their world-class standards of delivery. That's why we chose it, and we were not disappointed.
And what were the lessons learned? I mean, you're talking about the positive experience.
Exactly.
What were the lessons learned?
Yes, okay. So some of the lessons learned in Bundung is, despite the scheme, a lot of the women were still complaining of having to take out some out-of-pocket expenditure. What we do after these experiences is to speak to the women and say, what was your experience? We call it patient satisfaction surveys. Okay. Yes. So some of the lessons learned included, despite being covered, they still had to spend money. Exactly. So how do you alleviate that? How do you take care of that? A lot of others said, look, not only were we paying, but when we are going out, sometimes we have to spend money on medication. Yeah. Yeah. So it's a discovery. We're not there, but we have people interviewing patients who narrate their story. So how come you are covered and you still spend money either at the entrance or outside the clinic? So it allowed us to get together, engage the stakeholders in Bundung and find out, because it's not all the time you go there that they have all the medications necessary, So
after this piloting in July 2023,
right.
Have you been able to expand to other health facilities?
Absolutely. So after the Bundung experience, we were emboldened, and in April of 2024, we expanded to 13 facilities.
Oh, okay.
Yes.
From 1 to 13?
Yes, from one was Bundung, we added 12 to make it 13.
Okay.
Yes. Now, we had planned that in 2024, around October, November, to also expand to all the major and minor hospitals. So those 13 were the major health centers. We call them public health facilities. Okay. So mind you, the insurance is a public health insurance. We haven't started working with the private health providers. Yes, that will come, later on when we are stronger and are able to foster relationships or partnerships with the
Could you share with us some of the health facilities that you have expanded to?
Exactly.
After Bundung?
Yes, after Bundung, we did Kanifing, Kanifing General Hospital. Okay. Yes, Edward Francis Small. We also are in Bajakunda. We went to Essew.
Bajakunda, that's in Wuli.
Wuli, exactly. So it spread across. We work with the regional health directors. So all the major ones, including Brikama, Bajakunda, including Kanifing General Hospital, Edward Francis Small. Exactly. So now, we, as recently as April 2025, we have expanded to 67 facilities, including the 13. Okay. So now we're in all the major and minor health facilities in the country.
When you look at this whole scheme, I mean, how is this different from the current, public healthcare system that we have? How is it different?
Okay. The idea is to integrate, to come in and integrate, and in so doing, improve the experience. Okay. Yes. You want to improve the health outcome of the patients and their experience. For example, if in the current one, they had to take out a lot of money, this time you want to make sure before they even get to the facilities have all the essential medicines.
How do you do that? Sometimes you go to these health facilities,
yes.
They tell you we don't have the drugs.
Exactly.
So how are you going to do that?
Right. So we have what we call MOUs or contracts that we sign with these health facilities. Okay. So there is a possibility where we can pump in money, or pre-finance. Okay. They will buy whatever they want, and then using the claims mechanism. You see, we are a purchaser of services. The health insurance is designed in such a way that you send your patients, they get treated in advance, and then after the experience, a month or 2 or 3 months later, every quarter, the facilities will send their claims for reimbursement. Now, using our claims vetting officers, we determine whether this is right. The claims are based on verification. We don't take word of mouth for it. We have mechanisms where our people on the ground can ensure there is no fraud and that whatever is put in the claims request was what actually happened on the ground.
So, who is funding the authority?
Good question. The authority is funded primarily by the government of the Gambia through allocations from the Minister of Finance, Minister of Health, and with help from the National Assembly. However, we have very strong support from the World Bank. Yes, the World Bank has been our principal donor. Yeah, exactly. They help us in terms of operating expenses and also in terms of claims reimbursement. They set up some key performance indicators that if we meet, for example, if you have your enrollment thresholds going up, you get rewarded for it. Yes, so to answer your question, the government and the World Bank. Now, ordinarily, we should expand to other international donors like the USAID. They are also interested in health, which is no more.
It's no more.
Yeah, but there's still the global.
Unfortunately.
Yes, there's still the Global Fund,
which
is also working with the Minister of Health. Yes, so in future, there may be opportunities to have more donors come in besides the World Bank.
Because this is a great initiative. But how much is the government putting into this project and World Bank as well?
Well, as much as possible. It's a journey. When we started, the most important thing was the operating expenses of the authority. Are you able to pay rent? Are you able to get the utilities? Are you able to train your staff? And are you in a comfortable environment to work? That was year one. Year one, we were getting about $1 million from the government. Small, but good. Yes, they have to make sure your staff are paid. Yes, and then they're trained. And then you are now doing some communication or community engagement. Now, year two, it went up to 1.5, gradually. Year three, it went all the way to 3 million. So they're doing their best. Now, the World Bank comes in year three and says, for what you want to do, the small allocation you are getting may slow you down. So we're going to pump in some operating expenses, and then through the KPIs and the contracts and MOUs, if you perform, we have a budget of about $6 million to be used for claims reimbursement. So first they came in with $1 million to help us with operating expenses. So we were able to get a bigger place, hire more staff, train more people, get more utility vehicles. So that's significant.
Like I said, this is the first time that the Gambia is experiencing such. I mean, have you done any study in other countries?
Absolutely.
To understand how they operate?
Absolutely. You see, with insurance, and for most things in life, you don't have to reinvent the wheel. So even before the insurance started, the Minister of Health and all the relevant stakeholders went on what you call a study tour. Yes, they went to Ghana, to Rwanda. In our region, Rwanda and Ghana are good examples. Yes. Now, when I joined in June 2022, I also had the benefit with my small team to go to Ghana for a study tour. Recently, we organized a study tour, not for the staff or the board, but for the National Assembly members, the Health Committee, headed by Honorable Amadou Kamara.
Well, they enacted the
law that actually established
the authority.
Exactly. So, but after enactment, you need implementation.
Exactly.
Yes. How do you implement? By getting adequate funding. Besides the political will, it has to be translated into adequate funding. Now, for us to convince them that what we are about to embark on is pretty expensive, but it's worth it, we said, let's go see what's happening in other countries. So Rwanda was a very good learning experience. We've seen how they work together from their community health schemes all the way. You see, Gambia went into a national health insurance scheme. For most countries, they started at the community level, district level.
I say we were too ambitious just to go national.
No, absolutely. We are not saying that. What we are saying, we actually did what they are eventually going to do. You see, you start from the community, the region, and then you end up doing a national health insurance scheme. So we use the model of Ghana, which is a national health scheme. So we started at the right place. Recently, when the staff and board The one that I mentioned to Rwanda was for the National Assembly. Okay. When the staff and board went to Tanzania for a study tour, guess what their objective? They've been working on health insurance for the last 20 years. Now they're saying we're moving to universal health coverage by amalgamating all these fragmented schemes into a national scheme. So what we did in 2023, they plan to do in 2025. So it was the right model. Yes. So to answer
in terms of Rwanda and other countries, what were your key takeaways from Rwanda that you believe, as a starter,
yes,
we should focus more on this? Because, as a starter, sometimes you really have to manage your expectation and all that. Sometimes, yes, you can be ambitious, but you also have to be realistic, looking at the funding and all those stuffs.
Yes, the themes were common. Okay. From Ghana, Tanzania, Rwanda. The first lesson you learn is this is a long journey. Health insurance is a 50-year project. So you are not going to achieve universal health coverage in 3-4 years or 6 years. So be patient. Second, stakeholder engagement is very important. You have to get all the relevant people, Minister of Health, Minister of Gender, Minister of Finance. Everybody has to jump in and put their efforts on the table for this to work. Unity of purpose. In Rwanda, that's the first thing you see, unity of purpose. Everybody sings the same song. The president sets the tone, the ministers, everybody fall in line, the permanent secretaries, the CEOs, all work towards one goal. Yes. So that was also another lesson. Second, you need adequate funding through either taxes or donor support. That's very important. All three of them. Now, second, or the last most important was sustainability. Yeah? What the government is giving you is one thing. But you, as an authority or as a scheme, you have to find ways of sustaining yourself. In our case, our plan is to roll out to the segment of the population that is going to pay. Because for most countries, health insurance is supposed to be paid for by members. It's not supposed to be a free service. But where you make it a social protection scheme, you have to help the poor and the vulnerable. And our act states who should benefit free of charge. And those who, for example, I am able-bodied. I go to work every day. So the government should be able to take 2% of my salary every month, gross, and put it in the National Health Insurance Fund. So I am part of the public sector or the formal sector, but there is also an informal sector. Yeah. We've done actuarial studies that gave us indication levels of what to set for premiums. For example, this is just an example. If we say per annum, the people in the informal sector should pay $2,000. You pay that premium, and now you can benefit from all the services available at the public health facility. I pay 2% of my salary, and my colleagues and everybody in the formal sector does the same thing. The fund will have adequate resources to go, right? Now, that's part of sustainability. Again, in Ghana, we learned about the health insurance levy. So this health insurance levy in Ghana is a percentage on top of the VAT. So in Ghana, everybody who spends money in a hotel, in a restaurant, contributes towards it. Second, there is a mandatory contribution by everybody, whether you are private or public. Yes, so membership is mandatory. So
it's not about voluntary?
No.
Whether you want
or not. What is voluntary is your decision to use it. If you have the public health insurance or the national health insurance card, you can keep it in your pocket and still go do your own private arrangement. But because it is a social contribution, every month you contribute. And it's a token sum. 1%, 2% of somebody's salary may not be that high. So you are contributing towards the development of the health sector.
So in the case of the Gambia, for example, if I want to be part of this scheme, how do I join?
Good. You need two things. You need your electronic birth certificate. I hope you have one.
Yeah, I do.
Yes. Wonderful. Yes. It's not the elongated one. Yes. It's the A4 size. Yeah. Yes. Second, you have to, I think once you have that, it has got a NIN number. Yeah. Yes, and then you can be enrolled. But there is a difference between registration and enroll. So I have a health insurance card, but I cannot benefit. So I'm registered, but I'm not enrolled.
Okay.
Exactly, yeah? If you have your electronic birth certificate and your national health insurance card, you can go to any center.
Okay.
We are going to say to people to go to all the public health facilities. And maybe, eventually, at the NHIA headquarters, we will also have a registration window. But that's a decision we have to make based on resources.
Is there any registration fee?
No.
Okay.
It should be free of charge.
Free of charge.
Yes, free
And
of
as we speak, any
Yes.
idea the membership? How many people are you talking about?
Because our target population is narrow,
Okay.
it's pregnant women and newborn,
Okay.
yes, women presenting for delivery. We have enrolled over 22,000,
Okay.
yes, people. But like we were saying,
When you say you are doing well with this figure, 22,000?
it's modest,
Okay.
yes, but given some of the constraints and the limited resources, it's progress, considering that we've only been on for the last 12, 24 months. A case in point would be Ghana or other countries that have been doing it for 20 years and are still hovering around the 50% membership rate. So it's a long journey.
So this scheme, is it just for Gambians or anyone residing in the country?
Good question. It's meant for all residents of the Gambia.
Okay.
Exactly. All residents. You can't restrict it because universal health coverage is a universal human right. So all residents should be able to register either through your electronic birth certificate, your resident, I think there's an alien card.
Yeah.
Yes, for Gambian nationals, you can use your national ID card and all those biodata that you need. Yes, so it's for all residents of the Gambia.
I mean, you described 22,000 as modest. I mean, considering the period that you have been in operation. I want to know, you talk about the challenges that you face, aside from, I mean, limited resources. What have been your main challenge so far?
All right. Like I said, the slow absorption rate from the public. So we need to intensify awareness and stakeholder engagement. So we have to do more media campaign. We have been humble in the past, but you see recently, it's like a media blitz. We're everywhere, radio, television. We recently had a press conference. That's one major challenge. The other one is managing expectation. That is very important. If you remember...
Sometimes Gambians are so impatient.
Well, around...
Once it is created, they think you have to make it a success overnight.
No, actually, we get people telling us, I have this card, but I've not been able to use it. What's taking you so long? That's expectation. Remember, there was a time when we invited people to go to the centers, mosque, public areas. You know, I remember I went to Bakote, yes, Bakote, SOS Children's Village in Bakote to get my health insurance card. So we invited people to go to public places to get their cards. We couldn't keep up with the demand. We had so many people that there were fights, queues. You know, the paramilitary had to come and stop people. Others will say, well, I've been online for the last 2 hours and somebody just came and jumped the line. So we couldn't keep up. That's when we slowed down. Internet, I mean, the system crashed. And we wanted to do it everywhere. So managing public expectation is key. Then we came out and say we are only rolling out to pregnant women and children. Now people are saying, hang on, what about me? What about the pensioners? Well, it's not just pregnant women and babies who get sick, but it's a stage. It's phased. One at a time, we'll get there. It's a journey of what? 1,000 steps. You have to do one or two. Exactly. Okay. Yes. And lastly, like I said, sustainability. You know, we want to be here forever. If you want to be here for good, you have to design mechanisms of getting funding through partners, through government, and also through members who pay. Paying members will sustain the scheme if they see value.
Could it be some people are as bit skeptical about this whole scheme? I mean, maybe perhaps they have lost trust in our entire health system. I mean, you go to hospitals, there are no medication. You go to hospitals, they don't have the, you know, the required equipment to carry out certain, I mean, services that are needed in this country, to the extent that people have to travel outside the country for medical checkup.
True.
Couldn't that be the case, that people feel like there's no need to be part of this scheme?
Yes, that could be. But
when, as we speak, the government cannot even provide that needed, you know, healthcare services in the country.
That could be, but you know, we have a role to sensitize people, to increase awareness and tell them that there is light at the end of the tunnel. Yes. Before this scheme and after this scheme cannot be the same, because we are pumping in money in the facilities with which we have contracts or MOUs. So the experience is changing slowly but positively. Yes. So perception is not reality, but we are tackling that. And we are open to people. We have set up what you call a toll-free number, 1022. Where 1022 is our toll-free number, and that should increase.
It's operating 24/7.
Yes, it's operating. We have a call center.
1020.
1022.
1022.
Yes. So when you
let me try it and see. Continue. Yeah.
Yes, when you call the toll-free number, it's a helpline that should enable you to ask all questions, your concerns, your questions, all the perceptions that you have. You know, there will be people or operators. You know, Fatim is heading it. Yes, the head of PR and communication. So we are also going on radio. Yes, television, advertisements. You know, we'll do periodic press conferences, all of that to address some of the concerns.
I hope they are not having dinner.
So
it's not going through.
Maybe
they're having dinner.
Exactly. But it's good that you are trying it.
Exactly.
So that when we go, we can have the improvement that, you know, you should pick up the 1022 whenever it calls, whether it's 10 o'clock, except when they're sleeping. Yes.
No, but that's 24/7, at least there should be someone on.
Well, automated voices for 24 hours, but when it comes to individuals, there has to be some sleeping time. Yeah, but the message here is we're handling it. We want to engage the public to make sure some of their fears and questions can be answered. Yes.
You mentioned the case of like Ghana, where it is compulsory, whether you are going to, you know, utilize the service or not, you directly or indirectly contribute to this sort of scheme.
Yes.
Will you recommend for such in the Gambia as well?
In fact, we did. We are currently looking at an amendment of the National Health Insurance Act 2021. Yes. So hopefully if it passes, there will be an Act 2025, NHIA Act 25. So part of the amendment is to make the membership compulsory, yes, so that people can contribute. Whether you are part of it or you are not, or whether you are going to use it or not, because it helps sustain the scheme. Yes, and I think it's not just Ghana. In some Scandinavian countries and most developed countries, this is the thing. You have to give back to the public, and health is something that everybody is going to need. Whether you are rich, whether you are poor, at some point you have to benefit from the health system. So it helps to invest in it.
And so far, what have been the feedback from those who are registered? I mean, under this scheme, 22,000 is like it's a modest figure, but
yes,
I mean, it's a good start.
It's a good start.
Encouraging.
Well, the last time we did a press conference, we had a health practitioner from the Kanifing General Hospital who sort of gave us feedback that people are crying for it. So there is voluntary and increasing popular demand. In fact, people are telling us, why what is taking you so long to roll out these services to every part of the population? Again, like I said, if you do, you're going to crash under the system. The demand is so high. You know. Internally, we're discussing. Currently, we're doing just women presenting for delivery and 10 days after delivery for the babies. Now, what if we do antenatal and postnatal? That's a debate internally we're having. But we need more resources for that. Because when you take care of the baby from conception all the way to delivery, they become healthier. So you spend less at the end. So we come in at the end. But why don't we join the journey at the beginning? That's an internal debate. Not so. How about children under 5? What guarantees you that after 10 days, the baby is going to survive? Why not accompany the baby until they're 5 years? So these are models that we've seen in other countries. But it's going to take time and resources. And we're doing proper studies to make sure that we don't make mistakes. The benefit of coming now is that you get the opportunity to learn from the mistakes of other countries. And that is what is helping us.
So are you considering partnering with the private clinics?
Eventually, yes. Eventually. But for now, we want to do the 67 public health facilities very well. You remember, it involves having to credential them to check whether they meet global standards. Now, with the private health facilities, it's a different debate. Yes, so maybe in the next 2-3 years, it depends. Exactly.
Quite interesting. Well, viewers, you're watching QTV, the Gambia's first private TV station, and we are broadcasting from our studios here on Kairaba Avenue. My name is Ali Sise, and this is your weekly State of Affairs program. My guest this week is by Masen, who is the CEO of the Gambia's National Health Insurance Authority. We will go with a short break, and when we return, discussion continues. Do stay tuned.
QCell mooy suñu boss. QCell mooy suñu boss. QCell mooy suñu boss. Go, ebe dawa full network suda tili QCell. Ni lafta diamla wati jamala mune diata QCell. Most reliable network jumala geta wati QCell. Wo quality man nyon soda jam ona manke QCell. Hanibe wulo ni farole kono walante be bako na jala fayola network ko se taria QCell suñu boss. Ño fi njega indi 3G ñu delu taxi 4G plus and now we bring you 5G. 5G. First and only 5G provider. Suñu boss. Itella follow adi doron nesa keno. Suñu boss. Gambia bela nyon tawo fele QCell. Suñu boss. Ko fasun tawo buka busi QCell. Suñu boss. Itella molti milka kukutol nati Gambia QCell meta lori la kilianol yele imanyina amanda wala itella ka quality dila dadi ma itelle silo wala wodol mume be keno ma QCell suñu boss QCell suñu boss QCell suñu boss QCell suñu boss connection be bambandi QCell suñu boss QCell most innovative QCell suñu boss.
Hello viewers, welcome back from that short break. This is QTV, the Gambia's first private TV station, and we're broadcasting from our studios here on Kairaba Avenue. My name is Ali Sise, and this is your weekly State of Affairs program. My guest, like I said, is by Masen, who is the CEO of the Gambia's National Health Insurance Authority. By welcome back from that short break. I mean, we're still looking at the role of the authority. Yeah. Could you clarify, I mean, between the public and the private, as far as the authority is concerned?
Thank you again, Mr. Sise. So, like I was saying, our focus now is on the public health facilities, because for primary health care, they are able to deliver it. Now, but on a referral basis, where we need special care, for example, if our patients have ailments or conditions that cannot be taken care of at the public health facilities, that would necessitate a partnership with some of the private hospitals. Let me give you an example. If you probably need urological services, a surgery that is performed, say, at Sharab Hospital or Afrimed, definitely you're not going to get that service in a public health facilities at Brikama Hospital, right? Or Kanifing General Hospital. So in that case, it may necessitate a contract or an MOU between us. So that's what I mean. Maybe in the next 2 or 3 years, we'll explore those. But then it has to also fit in to our reimbursed mechanism. They charge far more. For example, if you had a C-section at Bundung during delivery, if it costs you, say, 15,000, if you go to a private hospital, it will be higher. It will be higher, much higher. So our reimbursement mechanism should also be in line with what we're going to pay. That's what I mean.
Like you said, for someone who is working in the formal sector, I mean, if you are part of the scheme, maybe at the end of the month you can just deduct directly from my salary. But for someone who is working in the informal sector, how are you going to address that?
There's an issue of disclosure. In the informal sector, you don't know how much they make. Well, unless the tax authorities have their own mechanism of finding out. So it's on a good faith basis for you to know. So you don't have to get into that. All you have to do is do your actuarial studies to measure the income levels, and you set what you call a premium. The premium says, if you want to be part of this scheme, you have to pay, say, $2,500 per annum, and you benefit from the services. So we will go, persuade them, sensitize them, tell them, you are paying a lot outside. If you join this scheme, you can have some savings. If you pay this premium annually, you don't have to worry about it if you go to our public facilities. So the premium takes care of that disclosure element, because I mean, informal sector, how are you going to know?
Yeah.
Some of them don't even bank with you.
They don't.
Yeah.
They don't.
They don't go to the banks to deposit their money. Yeah. Some do, but I don't know.
So in the event that I join the scheme and I register under Bundung Maternal and Child Health Hospital, I mean, is that the only health facility I can go to if I fall sick?
At all. At all.
Maybe someone from Basse might register in Basse and you choose to come to Bundung for delivery.
Absolutely.
Yeah.
The health insurance card is accepted in every public hospital.
Okay.
Yes. So for example, you are from Basse and you come to visit your relations in Kersering,
Okay.
you should be able to go to any public hospital within the Kersering and Bijilo vicinity, and they'll accept it.
Okay.
Yes. So you don't have to go back to your native village or community to be served. You'll be served everywhere. You can even proceed to Banjul, EFSTH, and they'll take care of you.
So how do you evaluate or monitor the effectiveness of the scheme?
Okay. So first, we have our credentialing officers.
Okay.
We have our claims vetting officers, and we also have what you call a monitoring and evaluation unit. Yes. Our PPME, we call it Policy Planning, Monitoring and Evaluation Unit. Yes. It takes care of that. Our Services Directorate takes care of the credentialing and the quality of service standards. Yes. So through also the patient satisfaction survey, because your most honest feedback comes from the patients themselves. They go through the experience and tell you firsthand how they felt. But we have independent people who do monitoring, our staff who do monitoring and evaluation. And when you work with partners, like I told you with the World Bank,
Yeah.
yes, they have a say. If they're putting money to improve the effectiveness of the healthcare delivery, they have a say. So they come with their experts, they do valuations, they look at your reports, they independently go. I go on field visits.
Okay.
The board chairman also has the opportunity to go on field visits, and through also the directorate of
Who's the board
health
chairman?
Our board chairman is Dr. Melville George.
Okay.
Yes, very experienced.
Okay.
Yes.
Okay.
So you have a mechanism to get 360 feedback in order to improve the services.
But so far, I mean, from what you have seen from all these health facilities that you have expanded to, I mean, have you received any complaint from them to say, I mean, we are getting patients, but we cannot provide it for what they expect from us?
No, not really. Patients maybe will give you that feedback, but health facilities, because they have a duty to take care of patients. Now, they can say, we have patients who are under the scheme, but we can't take care of them. Perhaps they will say, well, if we get more money from the Health Insurance Authority, we could take care of more patients. And then we'll say, yes, we are open to that. It's all based on how many people you take care of. The more reimbursement claims you submit, the more money you get back. Yes. So there's an incentive where also the hospital that performs to the highest quality standards also gets paid performance bonuses.
So how do you deal with a health facility that is not living, or that is not, living up to expectation? Okay.
Ideally,
because I mean, you're getting your support from the government. This health facility is also public health facility supported by the government.
Yes.
So how do you deal with that?
Okay. Ideally, there should be an annual credentialing exercise.
Okay.
Yes, that determines that this hospital or health facilities is living up to expectation. Okay. So there is like a scoring mechanism where, from A to Z, all the standards that have to be met can be done by our quality assurance and benefits manager. So the hospital or facility that does not deliver to expectation gets less benefits. Okay. So when we were rolling out, instead of saying, let's do a credentialing and eliminate some that don't meet standards, we say, let's give blanket approval for all of them to join. Now, after 1 year, we do credentialing, and the ones that fail the standards can now be put on probation, so we can have some corrective measures. You can be suspended or put aside, or you get a feedback for some improvement procedures. That is the plan. So the quality assurance manager is there to make sure they all live up to expectation. Otherwise, we give them less money. And the ones that perform beyond expectation gets more money.
And as we speak, are you considering expanding further to other health facilities?
We've done all the major and minor.
Okay.
Yes, so we want to test it for another 12 months.
12 months.
And then your question earlier, do we now add to the private. Facilities? But government is not stopping at these 67.
Okay.
Maybe within next 12 months, working with the Minister of Health, which is responsible for the bigger infrastructure, there will be new hospitals. You know, you've seen it recently. Yeah, the Minister of Health inaugurated some new hospitals. In another 12 months, there will be maybe 5 or 6. Yes.
It's good. I mean, they're building more hospitals, but I hope, you know, we also get more drugs and, you know, right personnel to man those facilities.
Absolutely.
Because that's one thing. It's wanting to construct a new structure, but having the, you know, the medical equipment that are needed to provide that service is another thing.
We have a role to play in that, and our role is both advocacy and make sure we channel the funds that we have through these facilities to help them improve. The essential medicines, without that, our scheme will fail. Exactly. So we are a primary stakeholder in the success of the general health system. Yeah,
because the scheme exists because of...
Absolutely. We're there to augment.
Exactly.
We're there to strengthen. Yes. So their success is our success. And we will make sure the funds we get from the government and from the donors will be put in there. Recently, the government, through the help of the National Assembly, the Minister of Health, Minister of Finance, and the President himself, has pumped in $50 million into the scheme. Okay. Yes, to say, year 1, year 2, you didn't have money, but now here's 50 million. It's modest, but start with it. We know within 2 or 3 months, the 50 million will be exhausted, but you would have achieved some improvement. And now when you go to the Honorable Minister of Health and Finance and say, help, I need help. They say, what's the problem? You say, oh, you remember the 50 million that you pledged to give me. We've already spent it, and it's only June.
So I want to know, because you're talking about the issue of reimbursement.
Yes.
We know the kind of country we are in.
Yes.
I mean, reimbursement. How do they do this thing? What is the process? I mean, people can just come and every day bring you receipt to your office and say, reimbursement, we had this person that came to our hospital.
No, we don't do that.
Okay.
Yeah, we don't do that. We don't work on trust. We work on verification.
Okay.
And we have built what you call an electronic national health information system.
Oh, really?
Yes, it's all done digitally.
Okay.
Yes. So from the input to the output, we have vetting officers who make sure that first, the reimbursement has to be in line with the standard treatment. So if I come guideline, if for example the presenting mother comes and you treat them for malaria, you can't present us a bill for pneumonia, for example. The head of our claims unit is a medical doctor. Yes, yes. The people working under her are well trained to detect fraud. So there is no chance. Yes, I know people are skillful. Yes, but so far we are working in good faith with the health facilities, and the electronic system submission and vetting ensures we don't accept manual claims processing. You know, through the World Bank, right from the onset, we said no manual processing because it encourages fraud. Now with the electronic system, from input to output, midpoint, everything is detected, validated before it comes for payment. So where if we ever have the potential problems I say, we reject the claims and we return it to sender and say, can you take a second look? Because it's not in line with your standard treatment, at our standard treatment guideline. So you can't treat somebody for malaria and then you are administering, for example, eye ointment. You know what I mean?
Exactly.
Yes.
Exactly.
So go ahead.
So in the event that, you know, for example, my colleague Ansumani Esonyazi is a member, and then, you know, maybe his brother is sick, is it possible to
use his card?
Yes.
It's individual.
Okay.
Yes. We don't have a family-based...
I ask because I know these are some of the questions that the viewers will be asking.
In the private sector, people do it.
Yeah.
You use your card and you use it. So there are schemes that are for families, and when you are registered as the father or the mother, your siblings or your children can benefit.
Or that also exists?
No, for us, it's individual.
Individual.
Yes, it's individual. And like I said, because our intervention so far is on the maternal and newborn health, yes, we haven't encountered that problem. But when we roll out to the formal and informal sector, you will come in, I will come in. There is a possibility of one person say, oh, I forgot my insurance card. Let me use yours. But guess what? There is a NIN number, right? It's a unique identifier. It's not transferable. So Mr. Aliou Cisse's card cannot be used because as soon as they key in the NIN number, the data comes up. And there is a picture representing. So they can tell Ansumana Eso Nyasi from Mr. Aliou Cisse. So it will be very difficult.
I know there are different categories as far as the scheme is concerned, if I'm right. But in the event that, I contribute maybe just 2,000 per year, and then maybe the services I ask for is far more than 2,000 a year. How do you deal with that?
That is inbuilt. We have what you call compensating inequities. Not so. So first, there is no class system in the insurance scheme. Everybody is entitled to the full range of services at any hospital. Now, if I earn more, I pay more. If my salary per month is $100,000, 2% of that will be more than somebody's salary who is 25. Yes. But what you contribute can get used by someone else because it's a pool. It's a pooling of resources. So you can't say because you pay less, you have to benefit less. No. It depends on your condition, your ailment, the diagnostics when you go to the hospital. So you contribute towards a social pooling. You understand what I'm saying?
I understand.
Exactly, yes. Okay. So I am helping. It's just like the visitor, for example, if we had a health levy, and then the levy was a percentage on top of VAT, the visitor who comes to Gambia and eats at a hotel will pay VAT and an insurance levy. But he may not even have the time to go to the hospital because he visited for a week without any ailment. If you are a resident, maybe you have the chance. But visitors, when you have a levy, will contribute without having to use it. The other bit is depending on my health level, if I'm a healthy person who exercises regularly, I may be contributing for 3 years before going to a health facility. Someone who's not that healthy can contribute very small amount per month and use it more frequently. But there will be controls. You see, just because you have health insurance doesn't mean that if you get a scratch, you have to go. Yes, if you have a headache that can be taken care of with a cup of coffee, you don't want to go to the health facility because it's free. So there are controls and deterrents. So
I would like to know from you, because you made something very important. Yes, the government is coming into support. Yes, World Bank is coming into support. I mean, you know what we are facing around the world right now. Donor fatigue everywhere.
Exactly.
I mean, your authority and the Ministry of Health, you are all competing for the same support from same donors. How are you managing that?
Well, coordination.
Okay.
Yeah. First of all, we all come under the umbrella of the Ministry of Health.
Okay.
Yeah. So there shouldn't be any miscommunication.
Okay.
Yes. I am the National Health Insurance Authority is always working constantly with the Permanent Secretary Minister of Health.
Okay.
We work with the Directorate of Health Services. So our demands and needs are known to them. There are regular updates. Yes. So there is no confusion. We are competing for the same resources, but we are very coordinated. For example, the Finance Minister and the Minister of Health go to National Assembly to argue on our behalf. We only accompany them on an as-needed basis when it comes to budget bilaterals, and we have to validate that what we have been allocated is enough, and we give feedback. Yes, so it's well coordinated, there is no confusion, and we are very consistent in what we do. Okay. Like I said, we didn't invent it. Okay. We migrate best practice from other countries, and then we follow. So
are you looking at, exploring other donors aside from the World Bank?
Yes, the Global Fund is here.
The Global Fund,
yes, so the question has always been, what will be the entry point? Okay. Where will they come in? With the World Bank, the entry point has been maternal and newborn health. Okay. Now, with the Global Fund, they're already into TB, malaria. Not so. You have seen them, AIDS, TB, and malaria. So we have to be more compelling and more convincing in our advocacy for them to come in. USAID for now
Yeah.
Off the table. But the other important bit about sustainability is to get the membership segment that will pay, so that the informal and formal sector can contribute to the future.
And that will only be realized
Yes.
if people start seeing the
benefits. Exactly.
The benefits.
Yeah. It's again stakeholder engagement. Exactly. We have to work with the Ministry of Public Service. We have to work with the PMO. We have to work with the Ministry of Finance. All that is coordinated and argued through a cabinet paper that has to be presented or spearheaded by the Minister of Health.
Yeah, because I believe with 20,000 members so far, you have good. You have ambassadors. I mean, if they are getting the services that they need from all these health facilities,
in fact,
we don't even need to go to the media to advertise.
That's precisely what I wanted to say.
Yeah.
The word of mouth is the best advertisement.
Yeah.
So
because
it's
they all come from communities and neighbors. So
and they have their own network.
Exactly.
Yes. So most of the demand we're getting is actually coming from word of mouth. But we have to complement it because the word of mouth there does not address the concerns, the fears. Now, when our staff, our stakeholders meet face to face with the communities, then the questions are asked, the responses are given. As we speak, I have 7 of my staff with the regional health directorates in the field, in all the 67 facilities going around from one center to the other. They're going to spend 10 days in the field to address some of these concerns.
And it's good if you can even go as undercover in this health facility just to find out what kind of services they're providing to members. But finally, CEO, what's your vision for the authority over the next 3 or 5 years?
Yes, in the next 3 or 5 years, we want to roll out to all the sectors, all segment of the population. We want to do the pensioners. We want to do the able-bodied, formal and informal sector. We want to do antenatal and pregnant women as well as children under 5. So the sky is the limit, but we have to be realistic what we want to achieve. It requires investment strategies. It requires working with donors, because at our stage, when more funding comes in, we have to maximize and say, we have assets, we have liabilities. Is there an opportunity to make money with some of the assets we have until we're going to need to pay? For example, if I know my claims payment cycle is going to happen every 3 months, I won't be paying claims before any quarter. So if I have idle funds, what should I do with it? I should invest it. But because some of the monies, or most of the monies, are coming from government and donors, you can't put them in treasury bills. So what are other investment avenues? We have a finance and investment committee that should be dealing with that. Are we allowed to do land banks, for example? Real estate, like they say in Africa, you can't go wrong with real estate. The authority is allowed to invest in profit-making ventures with the permission of the Minister of Finance. It's all stipulated in the Act. Yes, so there are ways of doing it to make sure this thing is self-sustaining.
In just a minute, your final message to your viewers.
Thank you. Yes, final message is maybe words of gratitude, thanks and praises, first to His Excellency the President for the confidence and trust he has in me, in appointing me to head the authority, and also to the Minister of Health and his permanent secretaries, to the board chairman and all the board members, but also very importantly to the staff and management of the authority. Yes, who support me and strengthen me to make sure we are able to deliver. But to our partners, the health facilities, because what we do, what we conceptualize, is only manifested through them.
And your 20,000 members so far.
Exactly.
22,000.
Exactly. So we have to thank the patients, the Gambian public, and really to everybody who has supported this in one way or the other. Some of your most important supporters are the ones that are invisible.
Especially World Bank.
World Bank, you don't know them. Exactly. The World Bank has been our principal donor. That's why when you see our conference calls, we have a branding where you have the Ministry of Health, the World Bank, the National Health Insurance. Also working. If we could, so to summarize, you just say Gambia government, because this one requires political will. And when it comes to political will, when the president sets the tone, everybody falls in line and tries to make it a success.
Thank you. Thank you so much, Bai Masen, who is the CEO of the Gambia's National Health Insurance Authority. He was my guest on the program this week. Bai, thank you so much for coming on the program. Quite appreciated.
Thank you for having me.
All the best as you embark on this very important national initiative. Well, viewers, with that, we bring an end to this week's edition of your weekly State of Affairs program. You can always watch this broadcast by visiting YouTube and just typing QTV Gambia. On behalf of the production team and everyone here at QTV, I thank you so much for watching and see you next week. Bye-bye for now. Thank you.